if your institutions are willing, if you want to do a multi-center study, you can go into an IRB agreement with IRBs, meaning that it would only require one IRB's review and approval.
Thanks, Lee.
Does anybody else have any other questions? Okay, if not, we'll take a break until 2 o'clock. the other locations came here, so, yeah. Okay, I'm trying to remember that.
Are your questions are like at the end, right?
Yeah,
Mostly?
probably,
Okay.
unless they interrupt me, you know,
Yeah,
I'm gonna,
yeah.
you know, so.
Oh, yeah.
But,
Just
probably
kind of
more
like
at the end.
do that so that,
What do I hit just to advance the slide, just?
just this right button.
Okay, right button,
I
okay.
know that Ken mentioned like signing, I'm just clicking it so it doesn't sign out on us.
Right, yes. That's good. Okay, if I could have everyone take their seats, please. We're going to get started a little bit early. Could everybody take their seats, please? Okay, I'm going to get started. I'd like to welcome you back for our third session today. Can everyone hear me? Okay. If I could have it quiet, we're going to get started again. All right. Okay, let me introduce myself. I've been introducing everybody else. I'm going to introduce myself. My name is Karen Hageland. I'm in medical education at Ascension St. John Hospital. I've been there 27 years helping residents like yourself with all phases of the research process. So how's the workshop series been going on so far? Did you enjoy the first two speakers? Yeah, okay, good. All right, so let's keep that momentum going. So my topic today is to discuss the basics of research study design. Earlier I asked how many were required to do a research project. Let me ask now, how many of you have started your research project? Okay, just a few of you. So most of you, I assume, haven't started yet. So you're kind of just at the beginning, you know that you're going to be required to do a project and you kind of are just getting going on it. So let me go through those steps with you. So you say, how do I begin? And it seems like a big thing to do, a research project, and it might be a little bit intimidating where you start. So what I'd like to say is take it bird by bird or step by step. This is Anne Lamont. I don't know if any of you have ever heard of her, but she's one of my favorite authors. She's written a lot of fiction and nonfiction works, and I guess it was maybe almost 10 years ago or so she came to at Grosse Pointe for an appearance, and I got to meet her. And she's actually coming at the end of this month to Ann Arbor, so I'll get to see her again. So maybe I'll update the picture here if I'm lucky to meet her again in person. But she wrote a book called Bird by Bird, and it's a guide to writing. It's not really medical writing, it's general writing. And how she came up with that title is when she was young, her brother had to do a report about birds. And he didn't know how to start, so he asked their father, how do I start a project? And the father said, well, son, take it bird by bird. And so that should help you focus on your study. So I say, okay, not bird by bird, but let's take it step by step. And one of the handouts that you have available to you online is a guide here with the steps of a research project. And you may find this helpful to check these off and to date them as you go through, so you kind of know that you're following the right path. And so here are the steps. So first you have to identify your topic. And this can really be anything. It can be something that just you have an interest in, that comes up in terms of your clinical work, maybe something that's suggested to you by a faculty member. And then you need to conduct a literature review. And that, as Dr. Zakaras told us earlier, you really need to go to the librarian to get some good help with this. You can do your own Google search, but they're really experts at this. You have to define your variables of interest. So maybe you're interested in patient satisfaction. Do you want to invent your own patient satisfaction scale, or do you want to use something that's already out there? And probably the latter. You have to come up with a research hypothesis that's precise and testable. And we'll talk about that in a minute. Then you have to design your study using the best design that you can based on your research question and the amount of time you have left in your program. You have to conduct what's called a power analysis. Does anybody know what that is? Dr. Smith is nodding. Of course you know, but what about the residents here? Not too many. Okay, well, I'm going to tell you about that a little bit later. You have to write a protocol or proposal. So this has to be shown to the Institutional Review Board. possibly a GME committee as well, depending on the requirements of your institution. You have to design data collection tools, so you can't just start looking at charts. You got to have an organized plan for that. You have to go through various committees, definitely the Institutional Review Board, maybe some other committees involved as well. Yet then you get to collect your data once you have approval. And you want to set up a spreadsheet, and like Dr. Zakara was saying, it's good to meet with the statistician to help with that. I know a lot of times residents kind of get stuck on this. One common thing that they'll do is the blood pressure, they'll put 120/80 in a cell in the Excel spreadsheet, and really you want to have a column for systolic blood pressure and a column for diastolic pressure, so you want to separate those out. So somebody from a statistical point of view will look at your spreadsheet and be able to figure out kind of what has to be done. So it's good to meet early on with your statistical person to make sure that you've got it formatted correctly. Then you can enter the data, and sometimes you can get a research assistant to help you with that, but they would have to be part of the IRB study team. Conduct the statistical analysis. Now, Dr. Zakara was telling you maybe you could do that on your own. I would not recommend that. Just like I wouldn't do surgery. You shouldn't do statistics. You should go with your expert at your institution. So you really don't want, I mean, you know, you'll get an output that looks good, but it's kind of garbage in, garbage out. And so if you don't really know what you're doing, yeah, you'll get p-values, but did you run the right test? And you want to really make sure when you're presenting your results, whether it's at your own hospital or whether it's at a local meeting or a regional meeting or a national meeting, that you really did the right statistics. So really meet with the person in your institution that's been designated to help you with this. And don't go it alone with that. Then you want to graph your data to really see what's going on with your data. You want to then generate a slide presentation or a poster presentation. And then hopefully write your paper for publication as a manuscript. Because you've done all this work, you may present it to your own hospital, but it would be really great to turn that into a publication. And a lot of times, I know at least at St. John, the residents turn in a manuscript as part of their graduation requirement. So it really doesn't take that much more work to format that for a journal and get that published so that you can share what you learn to the broader community. That would be a great thing to do. And of course, that would be a great bullet point on your CV as well. So those are the steps. So I think it helps to kind of break it down into those steps. So the first step then is, like I said, to identify a topic. And this can be difficult because you're going to be kind of locked into this topic. You really want to pick something that you're interested in, that you have a good attitude about. If you're handed a topic from a faculty member, it may be a doable project, but you may run out of steam halfway through and really lose your interest in it. So it really should be a topic that you yourself have an interest and want to answer a particular research questions, because it's going to be a long road to do a study. There's going to be a lot of bumps in the road that you don't foresee, and if you don't have the interest in it, it's really going to be, not a great thing to get through. So it may come from your observation, let's say, as you're rounding. It may come from discussion with your peers, with the faculty. You may look at a hot topic in your field. So if you keep abreast of the literature in your field, you kind of know what the hot topics are. Maybe you want to contribute to that. So those are all ideas as to how to identify a topic. Faculty research, I put that at the bottom because, just because a faculty member is doing something, it might not be something you're interested in. But if it is, then that would be a good thing too, because they may have an established program. You may be able to take a piece of a project that's already ongoing and call that your own and go with it. So it could possibly be a shortcut through this process to get involved with faculty research. And of course, then you need to come up with a research hypothesis. And this sounds simple. You learned this in Science 101 to come up with a research hypothesis, but you really have to be very specific. Sometimes the hypotheses are not really testable the way they're written. So you want to take your topic and come up with a research question, and then take your research question and come up with two hypotheses, actually. The null hypothesis, that of course predicts no difference, and the alternative hypothesis, which is what you really believe is going on, is that there is a difference in the outcomes. And so the hypothesis testing has to do with what question are you trying to answer? An example would be, will routine use of procedure checklists improve patient safety? Okay, so that's kind of a hot topic, is to come up with checklists, and certainly patient safety is a hot topic. And so your experimental hypothesis might be that procedures consistently aided by checklist use will cause fewer patient complications. Okay, so that's testable. We know kind of what you're doing there and what you're predicting. And the null hypothesis then is that it will not alter procedural complications. So those are two well-written hypotheses. And the goal of any research study and of statistical analysis is to disprove the null hypothesis or reject the null hypothesis. That's what you want to do. And in this chart here, you can see that we have truth at the top, and on the left side we have what you come up with from your study. And there's two cases here where you come up with a true conclusion. The truth is that a difference exists and that you find that, you reject the null, and that's a true conclusion. That's based on what the power is of your study, with the power analysis. The other way to get a true result is that there is no difference out there in the universe, and you conclude the same, that there is no difference. Where residents kind of get in trouble a lot of times is that they miss an effect. So the top left quadrant there is something that residents might get involved in here, and that there really is a difference. The truth is that there is a difference between these two patient populations, and you reject the null hypothesis. You come up with. It's the lower bottom one, the lower left one here, and that there is a difference, and you say there's no difference. So you make a type 2 or beta error. And why that's common in resident projects is that you just didn't have enough subjects. So you do not reject the null hypothesis. You keep the null hypothesis. You say there's no difference. And in fact, there is a difference, but you just didn't have enough subjects or power to show the effect. So that's a common error. A type 1 error is not quite as common with resident projects, but you really got to watch out for type 2 error. And another preliminary step is to define your variables of interest. So you have what are called independent variables and dependent variables. Independent variables are the groups or the cause and a cause and effect statement. And dependent variables are what you're measuring. So it's the endpoints, it's the outcome of the study. And you have to be careful when you're writing your protocol to define these operationally. And operational definitions is an idea that's been around for a long time. You have to define your construct in terms of how the operations are used to measure it. And this is precise. And this has been around from our friend, a Harvard physicist, Percy Bridgman, in the 1920s, coined the term operational definition. And so some are easily defined. So we all know how to measure height and weight and temperature and blood pressure. We don't have any differences about how to measure those. But if we have things that are a little bit nebulous, like pain, a little bit more subjective, patient satisfaction, professional competency, it's a little bit trickier to then define those because they're a little bit more subjective. And so in your study, you could come up with your own scale to define these things, but 9 times out of 10, if you look in the literature well enough, you'll find that somebody's come up with a scale for these things. You'd be surprised at how many different scales there are out there, and hopefully these scales, when they're published, have been validated, they've been determined to be reliable, and so it's so much better to take somebody else's scale and use it in your project rather than develop your own survey. So I had a resident a number of years ago who wanted to look at resident burnout, perhaps something you can relate to. And indeed, there is a resident burnout inventory. It's called the NASLOC Burnout Inventory. So this resident didn't have to invent his own scale. He could use a scale that had been validated. It's been validated for healthcare professionals. So that was a great thing to find that scale and be able to use it in the study that he was proposing. So you really need to go check with your librarians and check the literature and see that if you can get if you're measuring something a little bit more subjective, that you can get a scale that's already out there. Because designing your own instrument and determining it to be reliable or valid is a study in and of itself. It's probably not what you want to do as a resident. When variables are difficult to define, you have to give an operational definition. It might be a score, let's say, for burnout on the Maslow burnout scale. You've got to look for the experts for their operational definitions, and as I said, use standardized tests. So let me give you an example now, and I'm going to carry this example throughout the talk. So let's say my topic of interest is cancer and smoking. My research question then is there a relationship between smoking and cancer? My null hypothesis is that smokers are not more likely to develop cancer compared to non-smokers. My experimental hypothesis, which I believe to be the case, is that smokers are more likely to develop cancer than are non-smokers. Well, you may say to me, this is a silly area to investigate because we all know that there's a relationship between smoking and cancer that's been well established. Well, I'll remind you that in the 1940s and 1950s, there were ads like these in the medical journals. Yes, this was something that was in JAMA, in New England Journal of Medicine. More doctors smoke Camels than any other cigarette. So, I mean, it's hard for us to believe that at this point because we know this so well. We know this from a lot of projects, particularly the Framingham Heart Study. Big population study that's been done, but it wasn't always known. So let's just suspend our belief here for a minute and carry this topic through. So we're going to design a study that's going to look at this relationship, and we're going to say, who are the patients that may participate? We have a whole pool of people at our hospital. How are we going to choose who's going to participate? Well, what we have to do as part of our protocol writing is to come up with specific subject selection criteria. And you usually have both of these in your protocol. You have the inclusion criteria and the exclusion criteria. So the inclusion criteria, it has to be that everybody has to meet all of these criteria in order to be enrolled in the study. The exclusion criteria is if there's any criterion that is unsafe for the patient to be enrolled, then you want to put that on this list. It may interfere with the measurements, so anything that could preclude enrollment. And you can look in the literature to see for similar studies what people have used to include and exclude subjects. But you want to include as many people as you can because in the past, a lot of research has been done on white males. And why white males? Well, because they were a convenient population in a lot of cases. A lot of research is done at universities, and so that was largely the population in universities. So it is so much better than to include both genders if you can, racially diverse, ethnically diverse population, because the whole idea of getting your results then is to generalize to a wider population. So you really want as wide of a population as you can get from the beginning of your study, as long as it makes sense. Of course, if you're doing a study on pregnancy, you're going to only look at women, okay? But you want to include as many patients as you possibly can in your study. So an example for my smoking study, I want to include adults that are 18. I don't want to look at any adolescents who are smoking. I want smokers that are smoking at least a pack a day and for at least a year. And since I'm interested in looking at who's going to develop cancer, I want to exclude anyone who already has a history of cancer. I might want to exclude other things that could affect the lifespan of the individual. And I want to include, as I said, as wide of a range as possible, so gender, race, socioeconomic groups, to be representative of the larger population, so I have good generalizability or what's called external validity. And it's always best if I have a big group of people to pick from in my population is to randomly select them. Okay, so I don't want to maybe just look at the people over the last few months, but maybe I have 10 years of data. I could randomly select patients from that population. And how many subjects do I need? So this gets back to what I asked you in the beginning, if anybody had heard of a power analysis. So a power analysis, what you want to do is you want to answer the question, how many subjects do I need? And you may say, well, I'm going to review 100 charts, because that sounds like a good round number. That sounds like something I could stand up and present and not be laughed at. 100 sounds good enough. But it might not be good enough. What you really should do is approach this more scientifically. And if you make your best guess about the results based on published studies, if you make a best guess on what the effect size is that you're looking at, Then you'll be able to do what's called a power analysis with your statistical person. And if you're looking for a small effect, you're going to need more subjects. So it's kind of like looking for a needle in a haystack. You're going to need a bigger haystack. If you're looking for a big effect, then you won't need as many subjects. And so you really want to do the power analysis and put that in your protocol. And of course, a lot of journal editors are going to look for that too when you go to for publication as to what the power was for your study. In terms of the time frame, you want to estimate how long it's going to take to enroll patients. And if you're asking them to sign an informed consent, you have to imagine that some people just are not going to be willing to do that. As we heard from the last presenter, Ms. Boo's battle, there's been a lot of abuses in research in certain populations, and those populations may not want to hear anything about research because they know what's happened in the past. So, you know, you're not going to get everybody in your study that you would like to. So it may take longer to enroll patients than you imagine. You want to estimate how long then it's going to take to collect all your data, to enter your data, to analyze your data, and then be able to interpret it and prepare for presentation. So I've had residents, believe it or not, who have come to me on a Friday afternoon with their spreadsheet of data, and they're presenting Monday morning. So that's not fun for me. It's not fun for them. You know, I rush through it. You know, we get the preliminary results. They don't have any time to meet with their mentor to go over the results. We hardly have time to graph the results. If there's any kind of subtleties that they want to look at, maybe they want to ask, you know, is the effect that I'm seeing, is it different for males versus females, or African Americans versus whites, or you know, any question like that. We don't have time for any of those sub-analyses. You know, so you hardly have time for the results to gel in your own head, and then you're thrown in front of an audience to present. So that's not a good thing. So you really want to allow enough time for all of these steps and not be so rushed. Because believe me, you'll do yourself a favor, you know, because usually you can tell when a resident really kind of rushed through a project and slapped it together, and those usually don't go over quite as well, no matter how enthusiastic they present the results. There may be a seasonal variation in outcomes. So if you're looking at influenza, you're going to get a lot of those patients in the winter, you know, so, you know, it could possibly be seasonal variations. And you may not be collecting your data at the optimal season, so you have to think about that. But in any case, you need to allow plenty of time because all of these things are going to take longer than you imagined. You're going to run into roadblocks. Maybe your recruitment, it won't go as quickly as you imagined. You know, and so it usually takes longer than you imagine. So allow yourself plenty of time. And then you have to ask yourself, who will conduct the study? And at the top of my list here is yourself, because it's your study. You're the PI, you're the principal investigator. You have the most at stake. You may ask your fellow residents to help you, maybe collect surveys on the floor, notify you when an ideal patient comes in that meets your inclusion and exclusion criteria. You may hopefully rely on attending physicians or nurses, but you know, you can't always rely on other people, right? Because they're busy too, they're doing things, they may miss a patient and so forth. If you are going to rely on them, you want to make sure that at least you in-service them very thoroughly so they understand kind of how to help you with the study. You may want to give them an incentive, so maybe for every 20 questions that are collected by a nurse on the floor, he or she is entered into a drawing for a gift certificate. So you can't promise a trip to Hawaii because the IRB would say, well, that's coercive here. You don't want to, you know, but a small incentive could possibly help you with your data recruitment. And you want to make sure that the role of each investigator is very clear. And you want to do this at the beginning so there are no squabbles later on. And so, you know, define the order of authors and who's going to be an author and what everybody's going to do. And I don't know, at our hospital, we have what's called a subject team list. And so everybody involved in the study is listed and what their duties are on the study. So it's laid out right away with the IRB and everybody's clear on what their duties are. So there are some regulations from the uniform requirements for authorship, and that each author should have made a substantial contribution to the conception of the study, the design of the study, or the acquisition of data, or the analysis and interpretation of data. And all the authors should have helped draft the article and revise it, and also had the final approval. So you'll notice that I think that more and more journals are requiring each author to sign off on the study. And so even to this day, sometimes investigators get an email like that and they say, I never looked at this manuscript. What am I getting this email to sign off on this study for? I think it's happening a little bit less, but it still sometimes happens that you get these surprise emails in your inbox that, that somebody puts you on their study and you didn't really know, that you knew they were doing the study, but maybe you didn't see the final manuscript or whatever. So really, everybody should have played a role as defined here and also drafted the article and approved the final content before they get this email from the journal asking them to sign off on it. Okay. And if there are any questions at any time, just raise your hand. Any questions so far? Okay, let me continue then. So you also have to ask yourself the question, will the patients want to participate, especially given what we heard in the last talk? If they've heard about any of those things, I don't know about you, but I might not want to do research. I might not want to participate. But hopefully, if you give a clear explanation of the study and maybe there's a personal benefit for the patient to be enrolled, certainly you want to make sure that the benefit outweighs any risk, and the IRB will be looking at that very carefully. Sometimes patients are motivated to contribute to the advancement of knowledge, but certainly they have to be reimbursed for time and expenses. So if you're expecting patients to come in for additional blood draws as part of your study, maybe they have to fast them before there's blood draws. Well, it would be nice to give them a coupon for the hospital cafeteria to get a snack after their blood draw. Or maybe they have to take a bus to get to your hospital. So would it be nice to give them fare for the bus ticket? So you have to think of those things from a patient's point of view. What does it take for them to be part of my study? And am I reimbursing them for their time and expenses? I think that would be the right thing to do in these studies. Does anybody know what the Hawthorne effect is? Anybody ever heard of that? A couple of you, maybe, but not most people. Okay, let me tell you, this is an interesting story. And I think it'll underscore the idea of research design. So these were studies that were done outside of Chicago back in the 20s by Elton Mayo, who was an industrial psychologist. And he was asked to figure out what would increase worker productivity. Okay, like all industries are always interested in that. So these were people, workers on an assembly line making telephone relays. And what they did is they took the workers off the main line and they put them in a separate room. And they manipulated a number of working conditions, like how many breaks they gave them, the hours that they worked, the lighting in the room, the type of work that they were doing. And what they found is that no matter what they did, whether they dimmed the lights, whether they brightened the lights, whether they gave them more breaks or fewer breaks, whatever they did, lo and behold, productivity increased. And what they did then is they did what we call a focus group. And they asked them, why do you think this happened? And they said, well, I felt special. I was taken off the main line and I was put in a separate room, and I must be a super duper employee for you to single me out this way. Okay, so they were recognized for this. So they gave them what they wanted. Okay, so the experimenter manipulating the conditions in the room, it was really meaningless. Just the fact that they were in the room, they started making those telephone relays faster. So what does this tell you? Well, I think what it tells you is that you need a control group, right? If you just look at a group of patients and you ask them to, let's say, start eating better in the next month, exercising more, lose some weight, well, they might just give you that because they've been singled out. They've been put in a study. But, so you really need a control group. Maybe those patients, you gave them a whole educational program about healthy living. And maybe then you need a control group that you're also going to include in a study, but maybe you don't give them that instead. You give them something else, some benign thing that they watch instead. They watch a Disney cartoon while everybody else is watching a video about healthy eating. And so you've got a control group, you've got an experimental group. So now both of those groups know that they're part of a research project and they're being singled out. So then the bias for that is evened out. So it's always good then to design your study with a control group. So you want to strive to eliminate bias in your study. You can have bias come in when you're selecting your patients. Maybe you select the patients in your experimental group that come in on Monday and Tuesday and your control group on Thursday and Friday. Well, that's probably not a good way to go about it, because maybe the patients that come in at the beginning of the week are more eager to come in. Maybe they're sicker. They got sick over the weekend and they're there Monday morning. And maybe the people at the end of the week are somehow a little different. So you want to, randomly select people and not do it on the basis of days of the week, for example. You don't want to have any kind of procedural bias in how you select patients. You also have to make sure that your records that you collect, that patient data is anonymous, it's confidential. And you also have to make sure what you're collecting. You don't have to collect everything. I've had residents put in their patient addresses and zip codes and telephone numbers, and you have to ask yourself, well, do you need all that information? I mean, maybe you do if you're contacting the patients. If it's a telephone survey, well, you do maybe need to record their phone numbers then in order to call them. But normally you wouldn't have to do that. So you really want to only collect what you need to collect. So usually you collect demographics, because that's usually the first table of any paper is the age of the patients, the gender distribution, the racial distribution. You want to collect your risk factors, your outcomes. You don't have to collect everything but the kitchen sink. So be selective in what you collect. So you want to lay this out on a Word document typically before you conduct your study, so that you're very focused on what you're collecting. Okay, so you got some clickers on the way in. So I want to kind of wake you up here and involve you in a poll. So I'm going to ask the question, what type of analysis should be conducted to determine the number of subjects needed for a research study? Is it power analysis, analysis of variance, estimation of the amount of time you have before your project is due, or a t-test? So please, I know, yeah, we have a little glitch with that. Just ignore that. Okay, I'm going to take the poll now. Oh, that didn't work. Okay, here you go. Let's see. Got it here. Okay, everybody got it right. You might have noticed that there was a green check by the right answer. We had a little glitch with that, but so anyway, it's power analysis, right? That's what you need to determine. I mean, you also have to think realistically, how much time do I have in my program? Now, Dr. Zakaria is a PGY6, so he has a lot of time to do research studies. You might be a family medicine resident that has 3 years, so you might not be able to plan as grandiose of a project as he did and win a big prize, maybe, but you can still do some good work. So, but really, power analysis determines how many subjects you need. Okay, any questions up to this point? Okay, good. All right, so let's move on to the types of research design. And so on this list, the term, and for each of these terms, the one that's underlined, the one on the left, is the best thing to do. So it's best to have a prospective study, if you can, over a retrospective study. Now, I say that, but if you have limited time, and let's say you're looking at hypertension or type 2 diabetes, very common ailments, you can do a retrospective study because there's so many patients to pick from. If you're looking at some rare disease and you're planning to do a prospective study, that's going to be really hard because you probably won't have enough time as a resident. So it also depends on the nature of your research question and what you're looking at. But in general, prospective studies are valued more highly than retrospective studies. A controlled study, like I talked about the Hawthorne effect, you understand the need for a control group. That's so much better than an uncontrolled study. Randomly selecting patients is the way to go. And then being blinded to the group assignment. And there's different ways of being blinded. It can be the investigator is blind, and that's a great thing so that you don't know who's in the experimental group, who's in the control group. So any biases that you may have, any subjectivity that could go into things would be eliminated then if you were blind to group assignment. It's also good if the patients can be blind and not know which group they're in. And the considerations here is that the hypothesis should dictate your design, but often the time remaining in your program does. So if you start early, you're going to have more options, and you're going to be able to choose the best design that you can. And there's different study goals and study design, and your goal may be just to describe what's going on with patients, or it could be to explain the phenomenon. And if you have a descriptive design, that's a little bit easier. Descriptive designs include case reports. That's the presentation of one case. And that's great, to get involved in those as a resident. They look great on your CV to put on, that you wrote a case report. I know for internal medicine, you have the ACP conference where you can present case reports. So all of those look great on your CV. A case series is a group of related consecutive cases. Again, here the goal is just to describe these patients. It's not to make any determination of correlation or cause and effect. And then there are population studies. Now, these would be something that a resident wouldn't do, but the Framingham Heart Study was a big population study, looked at many generations of patients in Framingham, Massachusetts, outside Boston. A lot of important research findings came out of that. So to be able to describe the characteristics of a large population can be a powerful descriptive design. So they're not always not powerful. They can be very powerful. They can be a first step in research to describe what's going on. And then, of course, you all know this, they program a course evaluation. So like today, you'll be filling out a course evaluation on the program. So that's a descriptive design as well. The next step up the chain of the food chain, as you will, of research is to not just describe, but to explain. And you can have observational studies here and experimental studies. And observational designs, which is usually where resident projects fall into, are case control studies, cohort studies, and cross-sectional studies. And I'm going to go through each one of these and explain what those are and kind of what the advantages and disadvantages are. I'm also going to give you examples of these studies because I don't want to just talk about these theoretically. I want you to be able to apply it. And I'm also going to use some resident examples so that you can relate to these designs. So a case control study is a retrospective design. The starting point is the adverse event, and you group according to the presence or absence of this adverse event, outcome or disease. And then you want to find the risk factors that predict this disease. So an example would be going back to my smoking and cancer study. Let's say that you go through charts of patients who were diagnosed with breast cancer. Those are your cases in the case control study. Over a 10-year period, you examine their smoking history, and you compare this to control patients. These are patients in your hospital data system without breast cancer. Okay, so that would be a simple design to do with smoking and cancer. Here's one from the literature. I don't know if this was a particularly good study, but you see these kinds of studies. The question was, is there any association between drinking green tea and developing breast cancer in Asian Americans? And so they interviewed Asian women in Los Angeles, and they found 501 with breast cancer, 594 with no breast cancer. That was the control group. And they asked them to recall their dietary habits, including how much black and green tea they had drank. And lo and behold, they found that green tea drinkers had a decreased risk of breast cancer. Okay, so this was published. You hear about these kinds of studies a lot. So it's a case control study because you're comparing your cases to your controls. I think you can probably see the limitation of some of these studies. Look at how they were asked to recall their dietary habits. Well, right there, I start to think about, can you remember what you had for dinner last night? How long do you have to think about that? So how reliable, how valid is the data that they're collecting? Can you really remember how much green tea and black tea you're drinking? So they didn't take these women and randomly assign them to drink green tea or black tea in an experimental group versus something else in the control group. So, there could be some problems here making this interpretation. Here's an example. This was from an internal medicine resident at my hospital, and the objective here was to evaluate the efficacy of tigecycline in patients with gram-negative bacteremia. So this was a chart review project, so we had 29 cases and 87 controls. And what was found is that the cases were more likely to have come from an extended care facility. They had a higher comorbidity on the Charleston weighted index, and they had a longer time before they got an effective antibiotic. Those receiving tigecycline had a poorer immediate outcome and higher mortality. Okay, so here you've got a good example. This was a resident project, chart review, something that was doable, and you had your cases and you had your controls, and you can compare them on a number of outcomes. This study went on to our resident research day. And so the assessment then of these studies, the advantage is that they're good for an initial exploration of a topic. You can look at multiple risk factors simultaneously. They don't cost much money when you're doing a chart review. You may be able to get the data through a record review. And if it's a rare disease, it might be a good thing. Disadvantages, as I kind of alluded to, questionable data quality and having people recall their dietary habits. Or if it's a chart review, a lot of times the variables that you'd really be interested in collecting just were not recorded in the charts. There could be a recall bias if you're interviewing. Be sampling bias. You can only look at one outcome at a time because that's how you define your groups, so for the cases versus the controls. So you can't make any statements about prevalence or incident, and you cannot determine cause and effect. A cohort design, now this one, you follow patients over a period of time, and you group according to a risk factor. And you then compare the incidence of the outcome between those with the risk factor and those without. An example in my smoking and cancer scenario is that a researcher chooses a group of people, including smokers and non-smokers, records smoking data, and then 10 years later determines who has cancer and who doesn't. So you follow these patients 10 years later. An example in the literature is breakfast cereal. The question was asked, what is the association between breakfast cereals and the risk of heart failure? And so this was a physician's health study, kind of a population study that was done over a long period of time. And they asked 721,000 male physicians, so a big group, how much whole grain cereal they were eating. They did this at baseline and then various intervals after. They surveyed them every year for any new medical diagnoses that they came up with. And they found an association then between eating whole grain cereal and a decreased risk of heart failure. Okay, so studies like this get on, a lot of publicity online and in the 6 o'clock news and so forth because they kind of have a lot of punch, People say, okay, I should be eating more breakfast cereals. And of course, the breakfast cereal companies love this. So, this, again, you're asking them to report their consumption of cereal. So you didn't actually watch them eat how much cereal. You didn't weigh how much cereal they were eating, how much was in their bowl, and, So you had to be a little bit careful in how you interpret this. So an advantage of this design is that it's a powerful design to determine incidence. Recall bias cannot be a problem. It's a good choice when randomization is not possible. So you may not be able to say, okay, you guys eat cereal and you guys don't eat the cereal. Disadvantages is expensive because you got to follow up these people for a long time. So in this physician health study, this is a big project, and that they're following them every year to figure out how many diagnoses they have. And of course, the disadvantages here is that, okay, it's the time, the money. Attrition is a big problem because are the physicians going to stay with the study? They may say, I'm done with this, I don't want to answer your questions anymore. After coming back for talking to me for 10 years, I'm done. So, attrition is a problem when you're following long periods of time. Cross-sectional design. Now, this is something that a lot of residents do. You may not want to do the previous design was following a cohort for 10 years because you don't have 10 years in your residency. But if you look at a cross-sectional design, you get a snapshot in time. And this includes record reviews and patient surveys. And you can look at the risk factor and outcome simultaneously. So an example with my smoking and cancer is, let's say you give out a survey to a group of patients in a waiting room. And you ask them, are you a smoker? Are you a former smoker? So forth. Any history of cancer? And then you take all these surveys, you enter the data, and you try to figure out, is there any kind of relationship between smoking and cancer? So you get all your data at once. You know, you got people, got a captive audience in a waiting room, and you can collect the data. So you can see how residents like this kind of study. This is an example from a resident that I had, and this was on burnout. I was a family medicine resident a number of years ago, and the objective was to assess burnout among resident physicians in the Detroit area. And so he sent the Maslow burnout inventory, like I said, there is such a thing, to 71 family medicine residents in 8 programs. And he found that 51% were burned out. It might be higher now because this was done probably 10 years ago. And they said it was because they had a real heavy workload. And unfortunately, they thought that them being burned out really adversely affected patient care. And so this was a good study because he was able to collect all the data pretty easily with a survey and get the answer to his question as to what kind of problems, if burnout was a problem amongst residents and kind of what effects it might have on patient care. So that was a good study. That was cross-sectional. So advantages is that it's inexpensive and quick. That's why residents like these projects. You can get your data maybe through existing records or very easily through a survey. You can't determine cause and effect. Okay? You can't say, well, being burned out caused me to mess up this patient's care. It's ineffective for rare conditions. So you want to look at something that's common that you can collect very easily at your snapshot in time. You can determine prevalence, but not incidence. And it may not be generalizable beyond the patients that you collected in the waiting room. So the highest level of the chain